Assalamu alaikum wa rahmatullahi wa barakatuh. Hi everybody. Today I will talk about the approach to vasculitis, and we try to tackle some of the clinical related points that can help you during your clinical practice. So my objectives for today: we will talk about the clinical spectrum of vasculitis. We will describe the diagnostic tool to recognize vasculitis, diagnostic challenges, and its mimics. So these are a couple of cases from Johns Hopkins Hospital. I think these cases can brainstorm our minds to know how vasculitis is challenging and how much we need to concentrate and to rule out all differential diagnoses we have before label our patient as vasculitis. These cases published on Medscape, I think 2012. So we have first case, a case of female patient, 66-year-old, hypertensive with high ESR 90 and known to have BMR with slight weakness and in her left side, as well as altered mental status. This patient treated with high-dose IV methylprednisolone and cyclophosphamide, and the MRI revealed multiple area of stenosis or occlusions, and these areas related mainly onto the cerebral angiogram, with mainly in the extension of the carotid artery and the intracranial segment of the carotid artery, as well as middle and anterior cerebral artery. 3 months later, she developed visual deficit. At that time, GCA was raised as a possible differential diagnosis. However, the biopsy showed negative results. Treated by intervention through stenting the internal carotid artery, and the procedure complicated with diffuse hemorrhage, and unfortunately this lady passed away. The autopsy study of the previous lady showed that she has a severe extensive atherosclerosis and no evidence of vasculitis in her histopathology results. The second case for another lady, 52-year-old female patient, showed to have bilateral hearing loss and word finding difficulty. The MRI revealed regions of increased T2 flare signal in the left temporal lobe as well as Bohn's right occipital lobe. MRA and MRV were unremarkable, and her LB showed a white BC's count of 8 with lymphocytic predominance and normal glucose protein to rule out infection for bacterial mainly. CSF cytopathy revealed no evidence of malignancy. A chest CT showed nodular pleural thickening and posterior base of 2 small pleural base nodules, where was negative in PET CT for uptake. So the rheumatologist workup was done to rule out any underlying vasculitis. And here on your left side of the slides, you can find the cerebral angiogram showing the area of subtle multifocal distal vessels obliteration, suggestive of small vessel vasculitis. She was treated empirically with high-dose steroid, methylpred, and discharged hormone MMF and corticosteroid. After starting to taper prednisolone, the patient developed worsening of her word finding, again, and hearing loss. Again, altered mental status. Repeated MRI showed bitemporal inhibition. 4 months later, the patient developed increasing dyspnea, and the chest CT showed lower lobe opacity of the lung, left lower lobe opacity. And at that time, the echocardiogram showed severe pulmonary hypertension. Now we have a part disease related to our story and accessible. So a patient underwent wedge resection to reveal the underlying etiology for her complications. So the resection revealed severe intravascular diffuse large B-cell lymphoma. So in spite the PET CT was negative, the patient was having a B-cell lymphoma. Chemotherapy started, prednisolone and MMF were discontinued. Since starting the treatment, the patient's symptoms completely resolved related to her mental status, neurological, and hearing loss. So what about vasculitis? Vasculitis means inflammation. Itis means inflammation in the vessel wall. So we have inflammation in the vessel wall and it is heterogeneous. Any part of our body supplied by blood vessel can be affected. So that's why it's life-threatening and challenging in diagnosis. In your left lower side of the slide, you can find the normal artery. The normal artery, you will find a normal wall, the normal intima, and no cellular infiltrates. However, with vasculitis, you will find wall disruption as well as hyaline degeneration and lumen narrowing or sometimes occlusion, and there is multiple numerous neutrophilic infiltrates, these purple dots around the affected vessels or inside the wall of the affected vessels with wall disruption and nuclear dusts. So the process of vessel damage start with vessel wall inflammation, which may lead to increase the edema of the wall. That's why it can found in the MRI as edema and enhancement of the wall. And in such status, you can find the narrowed lumen, sometimes occluded. However, sometimes it's only narrowed and it can be occupied by thrombus, which is not easily to be embolic. The another consequence of this inflamed blood vessel wall is healing by fibrosis. Fibrosis will end with aneurysmal dilatation and unfortunately rupture and bleeding. So we have many classification criteria and we should know the difference of classification and diagnostic criteria. The first classification criteria proposed on ACR 1990, the start of nomenclature of systemic vasculitis started in 1994 by Chapel Hill Consensus, and finally the latest Chapel Hill Consensus nomenclature classification according to the etiopathogenesis has been announced in 2012. So it is not a diagnostic criteria, it is a classification criteria, and you should know the difference between classification and diagnostic criteria. Classification criteria allow you to examine a homogeneous group for research purpose. However, the diagnosis, you can have a patient diagnosed with vasculitis and despite not fulfilling the whole classification criteria proposed for this disease. This is the old classification of vasculitis, which depend mainly on the size of the blood vessel, either large, medium, or so. This is the latest Chapel Hill classification criteria depend on the etiopathogenesis as well as blood vessel morphology. You know that large vessel like Takayasu joint cell, medium-sized polyarthritis nodosa and Kawasakii, and the small vessel vasculitis divided into ANCA-associated vasculitis with its subtypes, with the nomenclature changes from a granulomatosis from Wagner granulomatosis to GPA or granulomatosis with polyangiitis, and from Church-Strauss into the EG. The another entity of the small vessel vasculitis is the immune complex related to the pathogenesis of the disease for the underlying vasculitis, like anti-GBM, cryoglobulin vasculitis, IgA, previously nocturnal purpura, and the hypocomplement urticaria vasculitis. All of these types are sharing the same pathogenesis of immune complex deposition type 3 hypersensitivity reaction. What about the variable vessel vasculitis was not mentioned in the previous classifications? It include Paget's disease and Cogan syndrome, because these two diseases sharing the same common features affecting large vessel as well as small vessel, which is uh, make them unique to have their own group entity. Another single organ vasculitis subtypes, which is related to one organ only affection in vasculitis, like cutaneous leukocytoclastic vasculitis, aortitis, isolated aortitis, cutaneous arthritis, which is mimicking isolated pan, primary central nervous system vasculitis. What about vasculitis with systemic diseases? You all know lupus, rheumatoid, and sarcoid can have underlying vasculitis pathogenesis and related symptoms and signs to vasculitis. And finally, vasculitis associated with probable etiology like drug-induced or as we know, hypersensitivity vasculitis, ANCA-related drug vasculitis, cancer-associated virus B, hepatitis B and C associated vasculitis, as well as syphilitic associated aortitis. So when you should suspect a case of vasculitis, when should we suspect a case of vasculitis? If you have a patient with multisystemic inflammatory disease, a known constitutional manifestation, high SAR and CRP plus low albumin as a part of the underlying inflammatory process, and then you will have an end result of ischemia, gangrene, or rash. Mononeuritis multiplex in a young age person asymmetrically should drag your attention towards the vasculitis underlying, so should be investigated well to rule it out. Rapid progressive organ dysfunction also could be a part of vasculitis, and leukocytosis, thrombocytosis with anemia is a part of ongoing inflammation and vasculitis related or other. It's not specific. Unfortunately, all of these finding is not specific to vasculitis. However, it can help to alarm you that we may have vasculitis with other differential diagnoses in the list. So the imaging of stenosis and occlusion and as well as aneurysm also can help you that we may have underlying vasculitis. So how to approach such case? So first, you should categorize the patient according to their age and related vasculitis. So if you have a young age, so we may, with a large vessel vasculitis, for instance, I will think about Takayasu. If I have an elderly with a manifestation of large vessel vasculitis, sure, I will think about GCA. So age can help in this context. You should create your problem list. Yes, I should have a problem list and check this problem list according to its priority. So I should prioritize it. In the second step, check which major organ affected, and these lists should fit in one story. You should find one answer for this active ongoing problem, and at the end you should rule out mimics before being confident for your final diagnosis. What are the common vasculitis mimics? Of course, on the top of your list is atherosclerosis, like our first case. It can associated with manifestation mimicking vasculitis and misdiagnosed unfortunately with vasculitis. Infection, of course, infection like encephalitis, endocarditis, HIV, sepsis with DIC, all of these manifestations can mimic vasculitis. Drug abusers and cocaine also can present with a picture like ANCA-associated vasculitis. Methamphetamines, paraneoplastic like lymphoma, our second case, also can mimic vasculitis and present like a case of vasculitis with whole blown picture that can affect the management plan if not suspected from the start. Fibromuscular dysplasia, it's like a genetic disorder, affect young females with normal ESR and CRB, so this is the clue in such cases. Coagulopathy like APS, TTB, all of these diseases can present with a picture mimicking vasculitis, and the management will be different than acute active vasculitis. Um, Amyloidosis and calciphylaxis also can present with a picture mimicking vasculitis. So I will concentrate on infective endocarditis because it's challenging to be diagnosed. Sometimes need esophageal echo to find the vegetations. It may resemble other vasculitis because it may share some of the autoantibody. So in a nice prospective study over 47 patients with bacterial endocarditis, interestingly, there was positive ANCA in 20 out of 47, and PR3 reported in 11 of them, and MBO in one subject. Another study, 109 patient with infective endocarditis, showed that the most common pathogen was Staph aureus, and the other 30% shared the Staph very dense and bovis. However, 39% of those patients showed negative culture. So negative culture will not rule out infection. This is another important issue. The ANCA testing also on those patients with positive Staph finding and negative showed that MBO and BR3 was positive in 8%. Other antibodies detected like RF and ANA as well as anticardlebins. Genetic disorders evolving recently in the era of 20s, and recently the mutation of adenosine deaminase 2 was associated with picture mimicking polyarthritis nodosa, and at that level any young patient with picture of PAN, you should investigate for the genetic testing related to DADA2 mutation. So at that level, you will find a patient with young age livid rash as well as CNS manifestation, immunodeficient, mostly to B cell lymphocyte, and autosomal recessive mutation, and of the DADA2. It's considered one of the autoinflammatory characterized by vasculopathy. So in the recent recommendation ACR 2021, they proposed that any patient with PAN-like manifestation in young adult better to be screened for DADA2. Fibromuscular dysplasia, you will have a female with presentation mimicking vasculitis, hypertension, headache, pulsal tinnitus, ischemic manifestations, with renal artery stenosis and carotid and vertebral artery affection in 75%. And the characteristic findings in the angio, you will have a string of beads. So this is characteristic, and usually those patients have normal ECR and CRB and presented younger in age. Unfortunately, end by dissection and aneurysm, multiple aneurysmal dissection, which is not common to be found in vasculitis. If you have multiple aneurysmal dissection, it will drag your attention toward fibromuscular dysplasia. And be aware that those patients females and may have low titer of ANA, so easily to be diagnosed as lupus vasculitis. Another mimics like cocaine-induced vasculitis. We have two types of cocaine, levamisole and the regular cocaine. And unfortunately, the levamisole type showed extensive cutaneous severe manifestation. And cocaine also may end with sinusitis and destructive septal perforation, mimicking ANCA vasculitis. However, the palatal perforation is not typical for the cocaine cocaine-induced vasculitis. So if you have a patient young age with palatal perforation, think about cocaine-induced vasculitis. Absence of systemic manifestation and skin plus upper respiratory tract affection can also guide for those patients. Unfortunately, the biopsy may show inflammatory infiltrate with necrotizing inflammation and vasculitis, and some of those patients will show also some positivity towards PNC ANCA. So now I have my problem list. I ruled out mimics, and then I should to categorize my patient according to his manifestation to the category of suspected vasculitis. So if my patient complain and findings related mainly to limb claudications, asymmetrical pulse or absent peri or imaging related to aortitis, I will think mainly for large vessel vasculitis. However, if my patient's manifestation related to cutaneous nodule with severe ulcers, or livido reticularis, or digital gangrene, or mononeuritis multiplex, or microaneurysms in the imaging, so at that time I will think about the medium-sized vessel vasculitis. At the end of my patient is having something related to the small vessels like skin, purpura, vesiculobolus nodules, urticaria, or the kidney like glomerulonephritis, lung-related alveolar hemorrhage, and cutaneous granulomas, splinter hemorrhage, uveitis, and episcleritis. So I will think mainly about small vessel vasculitis. So it's important to categorize your patient, and accordingly you can limit your differential diagnosis. So our next step will be to find the proper diagnosis for my patient. So now we have a list of differential diagnoses related to vasculitis or its mimics. To limit these differential diagnoses, I need to do some investigations. I will start with the lab investigations, which can be helpful to rule out related infections or coagulopathies, or can direct us to connective tissue related vasculitis. And then an imaging study also could be helpful, specifically MRA, MRV, and CT angio for the assessment of the blood vessels affection. And this angiogram is helpful mainly for the medium-sized and large vessel vasculitis. Echo CT chest also can be helpful to drag your attention towards associated vasculitis or infection related. So the conventional angiogram is considered one of the invasive techniques. It's catheter based. So that's why it's not commonly to be used until you have expert intervention radiologist. So we mainly depend on the MR angio and CT angio, MRA and CTA, to detect the vessel narrowing or aneurysmal dilatation or wall thickening in case of large vessel vasculitis, with specific sequences related to MRI. PET CT and ultrasound also has been added to our list of radiographic assessment of vasculitis. Another important investigation can help you to diagnose your patient is the biopsy. So tissue biopsy is helpful in vasculitis. So temporal artery for GCA, sural and muscle biopsy for PAN, leptomeningeal for CNS suspected vasculitis, lung, renal, skin biopsy also can help to rule out small vessel vasculitis. So what is the clinical features of large vessel related to Takayas? So as you revise this slide, you will not find anything related to small vessel, like lung, like skin. The only skin-related may associate with Takayasu is erythema nodosum. However, all the manifestations are mainly related to the affection of large to medium-sized vessel, and it may associated with fatigue, constitutional manifestation. Arthralgia is mainly may present with ophthalmic manifestation and visual loss like GCA, yes. So the age category here can help to differentiate the GCA from Takayasu, because they are sharing a lot of manifestation related. So MRA and CTA is a helpful tool for the large vessel vasculitis. This is a patient with Takayasu arthritis, and the MR angio showed on your right upper image multiple area of stenosis and occlusion, affecting mainly on the right common carotid artery, total occlusion, some irregularity on the left common carotid artery, and two occlusion at the level of the left subclavian artery. And here's you can show the wall edema and enhancement related to the aorta, ascending aorta. Here wall edema in a patient of Takayasu, and after gadolinium staining you can find the enhancement of the blood vessel, suggestive of ongoing inflammation. The point in Takayasu arthritis that those patients, when examined with MRA or CTA, you will find the chronic findings. So it's important to have a detailed history for those patients. So you should ask them about their daily activity, like their symptoms related to their showers, bathing, if they have claudication pain at the end of the shower, while driving, during, specifically for long distance, claudication of holding the steering, or any vertigo or transient loss of vision while looking to their sides as a part of the blind spot inspection. This could be related to vertebral artery affection of large vessel vasculitis. So it's important for those patients to ask a detailed history related to their daily activities, not just if you have claudication pain or not. Another important thing for those patients is CT angio is the best for assessment due to high resolution. But when you follow those patients up, you will choose the MRA if available in a good quality, because MRA lacking the radiographic the radiation exposure like what it's found in the CT, for instance. Another important issue, the GCSF, one of the iatrogenic cause of large vessel vasculitis and aortitis in some cases. So GCA, we will not go in details. We are talking about the approach to vasculitis, but you should have some idea about the main manifestation. You will know that the age usually more than 50, and the peak in 60s and 70s, and the ESR usually high, and recently CRP2. Abnormal biopsy, mainly granulomatous with multi-nucleated joint cells, sometimes associated with constitutional manifestation and PMR. And don't forget that those patients most severe or major complication related mainly to loss of vision and blindness. Those patients, up to 10%, may have a subtle large vessel involvement like in Takayasu. So as per guidelines, it's better to have a baseline screening for those, even if they are not symptomatic for the aorta and abdominal vessels. So the recent ACR 2021 recommendation, which mostly conditionally due to the low level of evidence. However, it's helpful and more practical. They recommend unilateral temporal artery biopsy, 1 centimeter, more than 1 centimeter, at least within 2 weeks of the corticosteroids or before initiation of corticosteroids. If the patient showed negative biopsy, it's still in the list. You can use the non-invasive radiological tool like ultrasound and PET CT. It can help. Specifically, this image for a ultrasound on a patient of joint cell arthritis, showing the characteristic halo sign of the temporal artery. Halo sign, the anechoic or hypoechoic area around the blue line, and both in longitudinal and transverse view, which is highly specific for the joint cell arthritis or the large vessel vasculitis in general. And this is the axillary artery showing the same halo sign longitudinal view. So as we confirmed previously, don't consider biopsy only as the only tool for the diagnosis of joint cell arthritis. You can use the other tools from the box, as ultrasound and PET CT also can be helpful. There is another interesting black blood sequence in MRI also can help in large vessel vasculitis. It can help to identify the edema and vessel wall edema, as well as vessel wall vasculitis, which was found to correlate with PET CT. So PAN and Kawasakii considered the medium vessel vasculitis related vasculitis. So in PAN, you all know it's a medium-sized vasculitis. So we don't have the lung, because the lung mainly in the small vessel vasculitis. The kidney affection here is related to medium-sized vessel affection, so it will end up with necrosis, high curiat, and hematuria. So it will not present like glomerulonephritis. Could be related to hepatitis B and C. A livido reticular is also considered one of the manifestations related to the PAN. However, livido reticularis could be also a part of the extravascular manifestation of APS. It could be also normal finding in normal population. So we will not go through the manifestation specifically for polyarthritis nodosa, but two diagnostic tools can be helpful. We can take a biopsy, not from the kidney of course, but from the skin in case of PAN related cutaneous ulcerations, and it should be deep and punch biopsy to get the arteriole and to get a proper sample for assessment. Otherwise your sample will be negative for vasculitis and will be misleading for you. Another important issue is the imaging. It could be helpful also, and you can find the multiple aneurysmal dilatation with the commonest site mainly in the abdominal vessels and the renal artery, which could be associated with area of stenosis and aneurysmal dilatation like this patient. That's why one of the commonest manifestation is the abnormal blood pressure. And you can find also multiple aneurysmal dilatation into the renal medulla, and of course the cortex is not affected here because it's related to the small vessel vasculitis. So if I got a biopsy, it will end with an area of necrosis rather than area of vasculitis. So the ACR also 2021 recommended for diagnosis of PAN imaging abdominal vessel bunch biopsy for the skin. And if you're having a polyneuropathy, so you may have a nerve biopsy as well as muscle biopsy to confirm. It's important. They also recommended against plasmapheresis because they found that the way of benefit related to risk for those patients is low. So unless you have a patient with severe hepatitis B viral related ban and plasma exchange at that time or phases can help. Another issue, if you have a patient with end-stage renal disease and life-threatening condition and you used all your guns, so plasma exchange could be used in such instance. Um, as we have mentioned earlier, the two should be screened if available for those patients with young age and presented with ban-like manifestations. So Kawasaki is considered a pediatric-related vasculitis. However, it also can occur in the adolescent as well as the adults in a rare context. Recently, the Kawasaki, after the era of the COVID-19, has been proposed as different and the rather than the COVID-related Kawasaki-like disease or multi-system inflammatory syndrome. So multi-system inflammatory syndrome is a post-COVID syndrome that can mimic Kawasaki and treated in the same manner. The only differential is the history of COVID infection. I think this is the weight mainly for the history taking and the positive PCR for COVID before Kawasaki to be ruled out. Because it's challenging to differentiate is it Kawasaki or multi-system inflammatory syndrome. But I think at least both can treat it in the same manner. However, the prognosis is different. So that's why we should know, is it true Kawasaki or multi-systemic inflammatory syndrome. So variable vessel vasculitis, these groups sharing a manifestation related to small vessel vasculitis as well as large vessel vasculitis. Like Cogan syndrome, it's considered a rare condition, usually presented with non-syphilitic interstitial keratitis, acute onset sensorineural hearing loss, and vestibular symptoms like Meniere's disease, and usually they have they will have hearing loss within 2 years. Also, there is coronary artery affection as well as aortitis, with aortic valve affection as a part of the large vessel vasculitis. Behçet's disease or Behçet's is considered one of the variable vessel vasculitis. It has demographic characteristics in the Mediterranean basin, Korean and Japan, or previously known as Silk Road related disease. Usually the onset is after 20s and rare before 50s. So easily to diagnose if you think about it. The commonest manifestation you all know is the oral ulcer. So plus genital ulcer, you should check under the scrotum. It's one of the hidden area. You can have an ulcer and not seen even by the patient. And the positive pathology test, oral ulcer or uveitis, like this patient with hypopyon. Hypopyon up to 20% associated with severe. So why Behçet's disease is challenging? Because the acute phase reactant is not common to be there even with active disease unless you have erythema nodosum, arthritis, or vasculitis related. No autoantibody, even the B51 is not specific. Only in 28% of Turkish population may have B51. Pathology test not sensitive enough in spite being specific. However, it's even getting less prevalent in the recent years. We have two classification criteria for Behçet's disease could be helpful due to the challenging situation. The old one, the international study group criteria, and the recent new international criteria. The issue with the new international criteria being more sensitive, it's less specific, and the false diagnosis of Behçet's disease is more prevalent in the new criteria. So most of the experts recommending the international study group criteria for classification of Behçet's disease because it's in spite being less sensitive, it's more specific, and the wrong diagnosis is less with this criteria. Even though there is a study compared the both classification criteria and showed um, a positive input related to the international study group criteria. Um, so some tips could be helpful with Behçet's disease. Those patients will have neuroparenchymal lesion mainly in the mesencephalic junction and brainstem. Peripheral nerve is atypical for Behçet's disease, so think for another cause. Vascular sinus thrombosis is common in Behçet's but not in other vasculitis. Pulmonary aneurysm and could be also associated in large vessel vasculitis like Takayasu, not only in Behçet's disease. However, in Behçet's, the pulmonary aneurysm usually associated with thrombosis and commonly found in the middle and lower right loop. It could be bilateral. It may need surgical intervention. However, it's high risk because of the associated bathyergy in the blood vessels. It's considered one of the Kapner phenomena. Sometimes it's associated with IVC thrombosis. Also, positive bathyergy test can occur also in Sweet syndrome and biderma gangrenosa. Fever, edema nodosum, collateral with superficial thrombophlebitis. Please think about ongoing vasculitis of the head and vessels and large vessel vasculitis, specifically pulmonary aneurysm. Genital ulcer and Behçet's could be on the scrotum, shaft of the penis, but it is away from the urethra, not desquamated. It tends to scar. However, if I did not see a scarred ulcer in Behçet's, it will not rule out Behçet's. So it tends to scar. Some patients will have a scar. Another important issue, not all scarred ulcers is Behçet's. We may have scarred ulcer in other infections like syphilis, leishmania, and lichen in women. Final group we will talk about today the small vessel, and the common feature, as we've mentioned before, skin, lung, kidney, and neurological manifestations. What about ANCA-vasculitis? It has a characteristic triad like upper lower respiratory tract affection as well as the kidneys. Histopathology usually having a geographic necrosis with large area of necrosis and joint cell infiltration, which is a marker of granuloma. There is two important recent studies has been published related to ANCA-vasculitis. You should be familiar of, like RAVE study and VEXAS. This is a patient with ANCA-vasculitis from this ACR album. You can find the characteristic saddle nose. However, you should ask your patient, is this saddle nose since birth or recently developed? Because some normal population may have this configuration of the nose without being vasculitis. Subglottic stenosis, one of the manifestation related to ANCA-vasculitis, and it will be present clinically by recent onset of snoring, so it's important to ask in the history. And of course the characteristic multiple nodular lesion in the lungs, with some of them are cavitary nodules, is characteristic for the ANCA. This is a CT chest of patient with ANCA-vasculitis with one of cavitary nodule with no fluid level, because if you have fluid level it may goes mainly for more for the abscess for retroorbital granulomas, which could be also manifests in the CT, and this CT also show the perforated nasal septum. The biopsy in ANCA-vasculitis is helpful more than the radiological findings because it can help to identify the proper diagnosis by the characteristic necrotizing vasculitis or granulomatous vasculitis. So the granulomatous vasculitis for those patients is common from the lung biopsy and not by the bronchoscope, by the wedge biopsy. Open lung wedge biopsy it can show the granuloma well. However, any scopic biopsy will be fragmented and hardly you can find the granuloma. The EGBA difference is we have an extravascular eosinophilic infiltration, which is characteristic for EGBA. Kidney biopsy usually necrotizing vasculitis and rarely to have granuloma. Only 3% reported granuloma from the kidney biopsy. Pussy-immune necrotizing glomerulonephritis is the characteristic finding in case of ANCA-vasculitis, and those patients also may show the same pattern of pussy-immune necrotizing glomerulonephritis in rare cases of infection and malignancy. So this is the 5-factor score proposed in 1995. It depends mainly on the proteinuria and high creat level with a specific gastrointestinal manifestation, severe affection, and cardiomyopathy as well as CNS involvement, mainly polyneuropathy, motor, which can end with motor at the end, start sensory and end motor. And this 5-factor score proposed to help treatment of patient with ANCA-vasculitis or any other vasculitis, even PAN. And it shows that those patients with high 5-factor score have a high prevalence to have mortality rate rather than others. 2011, the 5-factor score has been revised, and proteinuria and CNS 2 items has been omitted and added age more than 65 and patient absent ENT manifestation. According to their finding, they have found that their high statistical significant mortality rate with patient more than 65. Another also issue, they have found that patients who are having ENT manifestation, it was associated with better prognosis and less mortality rate. So that's why they included these 2 points. Proteinuria not associated per se with high mortality rate according to their results, and also the CNS mainly was associated with the polyneuropathy, and they found that polyneuropathy, even if end with motor and paralysis, it will affect the functional status rather than mortality. So that's why CNS was proposed to be omitted from this new 5-factor score. Still, the old or 1995 5-factor score is used more in clinical practice because it's more applicable all over the all medium and small vessel vasculitis, including ANCA. So recently, as we are now in the era of genetic studying, they found that those patients who are male refractory to treatment with recurrent fever and manifestation of ANCA-vasculitis like lung and skin with pulmonary affection and hematologic abnormality may have abnormal genetic studying with which known as VEXAS syndrome. VEXAS syndromes means vacuoles in the myeloid precursors, ubiquitin activating enzyme, X-linked autoinflammatory somatic mutation. This VEXAS syndrome have found to mimic a lot of vasculitis, but mainly ANCA-vasculitis, but also it can be found in Sweet syndrome and joint cell arthritis. It's somatic, not inherited mutation for autoinflammatory disease, and it should be suspected in patients who is resistant to treatment, and in such case, screening for VEXAS syndrome is recommended. A patient with EGBA, you should do echocardiogram from the baseline, even if the patient is not symptomatic, because subclinical myocarditis can be detected and can be treated early, because this is the most most complication of EGBA that associated with high mortality rate, rather than other ANCAs vasculitis. As we've mentioned earlier, 5-factor score can guide therapy, and they're talking about the 2011. So I will end the presentation with two interesting cases from our institute. She's a 23-year-old female presented to ER with jaundice, abdominal pain, history of recurrent oral ulcer joint pain, malar rash, hepatomegaly, positive shifting dullness, lymphopenia with high SDLT, more than 5 folds, and the INR was 5.1, low albumin, 24-hour protein in urine is 1.1 gram. NA was positive, DNA was positive too, and at that level the patient diagnosed as SLE. So what about the hepatitis? Is it related? Is it associated? So the autoimmune hepatitis panel has been done for her, and it was negative. Another ceruloplasmin level enzyme has been assessed to rule out Wilson's disease. Unfortunately, biopsy couldn't be done for both kidney and the liver, because the INR was 5 and the patient was in liver failure. And we started to give her pulse steroid, and at that level the patient started to develop in the third pulse severe hypoxia, as well as recurrent attack of convulsions, admitted to the ICU, intubated, and it was about 3-time intubation, 8-time intubation and extubation, and tracheostomy was discussed with the family. Chest X-ray, HRCT showed pulmonary edema. However, echo was normal. The blood pressure was not controlled, 210/120, and the MRI ruled out the renal artery stenosis. Catecholamine level was done, and it was normal. So at that time we proposed cardiac catheterization, and interestingly it was a diastolic failure. For MRI for the brain showed multiple area of intensity, increased intensity, mainly in the posterior segment, or the posterior fossa. However, anterior fossa also shows some area of hyperintense signals, MRI related, and it was not restricted in diffusion. And two possibilities at that time, maybe post convulsion or Press syndrome. And this is her CT chest showing the batwing appearance, suggestive mainly for pulmonary edema. So the patient tapered steroid and maintained on antihypertensive, and treated for diastolic failure. Unfortunately, she was extubated, and the MRI follow-up showed normal MRI, which was consistent mainly with the Press syndrome, and at the end the patient diagnosed with SLE, induced hepatitis, and lupus nephritis, and a complication of steroid in the form of diastolic failure, malignant hypertension, and Press syndrome, which was reversible after discontinuation of the steroid. Another case, he was a young male, a 21-year-old, diagnosed at the age of 16 as a case of GIA, with 7-month history. 7 months history of a CNS manifestation like impaired vision, which revealed pale optic disc upon examination, bilateral cerebellar pyramidal syndrome, sparing the face, weak in lower limbs, and sensory level at T5-6, with dissociation, urinary sphincter disturbance. He has recurrent painful oral ulcer, and upon examination there is active and scars of previous genital ulcer. So he was having active genital ulcer as well as scars from previous genital ulcer. Rheumatoid factor was positive. Maybe this is the cause with the arthritis to misdiagnose him as GIA. HLA-B51 was positive too. Acapurine antibodies were negative. CSF, no oligoclonal band has been detected. Skin pathology test was positive for this patient, and the diagnosis of Behçet's disease with neuropehçet's disease was proposed, and I think it was even it started during his age of 16, but for unfortunately labeled wrongly as G. This is his MRI, showed multiple hyperintense signal in the spinal cord, as well as into the medulla, and the brain MRI is completely normal, and this is the axial of the sagittal MRI for the same patient. This patient, the diagnosis was for this case was at the 2014. So at that time, discussed with the neurologist, he proposed that the Bale optic disc is denoting a history of optic neuritis previously, and this could be a patient with neuromyelitis optica, could be association or could be related to Behçet's disease. This patient was treated successfully with balstisterone and cyclophosphamide, even though his MRI later on for follow-up reported normal by the radiologist. And these two interesting cases I'd like to share with you to show you how sometimes we may have association, we may have a drug toxicity that can mimic even vasculitis, and also it should be ruled out even with the context of active vasculitis patient. We should even differentiate within the case itself. Thank you for listening, and hope to meet you soon in the coming learning episodes. Thank you.